This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with offices in Midtown Manhattan and Wayne, New Jersey.
And I'm Marina Kurian. I'm a general surgeon, but I do a lot of minimally invasive surgery and weight loss surgery in New York City.
We have a great show today. We're going to be talking about children and adults. We have a wonderful pediatric interventional cardiologist on. Her name is Dr. Nicole Sutton, and she's at Montefiore Pediatrics, Montefiore Children's Hospital. And we have Dr. Vic Pamoukian on. He's a vascular surgeon for adults and assistant professor of surgery at Northwell Health and Lenox Hill Hospital. And we are going to talk to them both about basically blood vessels up and down and sideways throughout the body. So if you know people who are interested in this subject or any subject having to do with medicine and would like to watch, please ask them to please hit share and like and tag them and ask them to join us. We are live on Facebook and YouTube and Twitter, and we are closed captioned on YouTube and Facebook.
Yeah, I just want to say, though, this week's show may not have any sideways blood vessels. Just saying. We have to ask our guests.
Oh, I don't know. Look at that pulmonary artery and vein, Marina. I beg to differ.
Okay. So we're going to learn a lot from them. We're so excited to have them. But as you guys know, we're going to talk a little bit about the news of the week. And I just want to say that I'm so much less stressed these past few weeks, right? Talking about the news of the week. We have so much positivity in terms of what's happening with the vaccines and what's happening with COVID, because of course we have to talk about COVID, but I'm feeling so relaxed, Sujana, that I almost feel like I can go without my Botox to hide my frown and upsetness, right? Like it's so much better.
So I feel like I've earned all these wrinkles, so I'm just going to keep them. But I agree with you. I think, our numbers of cases are going down. Our numbers of vaccination here in the United States are really good. We're vaccinating over 2.5 million people per day. Yesterday's number of over 4 million, I think, just reflected a couple of days together. But lots of places have 24-hour opening. We have, in the United States, 3 vaccines working now. And the Pfizer vaccine shows 94% effectiveness against asymptomatic transmission of COVID, which is the data from Israel, and it's really effective against the UK variant, which seems to be much more contagious than the others. So that's really exciting. I want to tell you, my parents are currently in India, and they're watching from Bangalore, India. Maria Eftimiadis is watching from Sag Harbor, Long Island. And I'm just going to do a family show because my sister says Happy Pi Day 3.14 to everybody. And my cousin, who is a pediatric cardiologist in Johnson City, Tennessee, and really helped us out preparing the questions for this show, Rajni Anand, is watching from Dolly Parton's home state of Tennessee.
Your poor cousin. You're like, oh, and my cousin who lives where Dolly Parton does.
Or Dolly Parton lives where my cousin does. How's that?
That's what you're saying now, but you know how you feel. So yeah, that Pfizer vaccine, that's just excellent news, right? Like if we pop that back up, the other thing was it showed, if we put that slide back, that it showed that it was 29 times more likely if they were not vaccinated. And this is, as we said already, all data that came out of Israel. And it's really just really amazing what we've done in such a short period of time. And so this is part of the hope that I was speaking about, that we're going to be able to really turn the tide of what's been happening. And I think that's already slowed. But We want to also look at, President Biden put out a fact sheet, which I think is really great. And he has made some changes. This past week, he announced that all Americans should be eligible for vaccinations by May 1st, which is really fantastic. It's almost unimaginable, but we can have small get-togethers by July 4th. I think that is really fantastic. And also, how about the fact that we have briefings now, which I think is so amazing. I could pull that right off the government site, which I thought was great.
I agree with you. Kes Bass is asking, is there a new variant in New York City? And part of the reason we know the answer to this is because we are getting these briefings. Yes, there is a new variant in New York City, but in fact, we believe that there are new variants all over, and we are finally starting to test for those variants. So far, all the approved vaccines are helping significantly in terms of moderate, serious, and severe disease that needs hospitalization from all of the variants, which is really good. Speaking of vaccines, we talked about the US numbers. Israel still leads in terms of vaccines per 100 people. So they have 104 vaccines per 100 people. So I guess a couple of people.
That seems weird, right? But
that seems weird.
That's wonderful. But I think this is also important because, you can see what each of the countries are doing. And it's just a nice look at what we're able to do and how the vaccination process is going around the world. Unfortunately, not every country is on this list, right? The world, if you look at the world data, they lumped everybody else in, is just under, is significantly smaller, just 4 per 100. And I think it also has to do with how the vaccines are being distributed. And also, people are saying in the US, if we have 800 million doses or vaccines to be administered, then we might be hoarding and we may have to share.
Yeah, the World Health Organization issued a call yesterday or the day before saying 130 countries have not started vaccination. So we are not out of the woods until everyone who can be vaccinated is. Like, herd immunity means 75 to 80% of all of us. Children are undergoing the Moderna trial right now, between 12 and 18 years, and it seems that those vaccinations are going to start pretty soon. In the next, maybe after about 2 months, we should get enough data. So what happens once you get vaccinated? Marina, do we just rip off our mask and just go, celebrate? What happens to us?
Yeah, well, that we know what we're going to do, but thankfully for everybody else, the CDC has also issued some guidelines. So if we can pop up that slide, the CDC basically saying that if you are visiting with someone else who's fully vaccinated and you're indoors, it's okay to not wear a mask. Or if you're fully vaccinated and you're visiting with unvaccinated people who are at low risk for severe COVID-19, then you can also visit with them without wearing a mask or physical distancing. But the other important thing is we don't have to quarantine if you're fully vaccinated. You don't have to test if you're asymptomatic, if you know that you've encountered someone who has COVID-19. And these are big changes, that we've undergone since the start of all this, since last March. So in the course of a year, we've almost gone 180, right? Not full circle, but 180 in the other direction. But that has to do with the vaccinations. You still want to take precautions like wearing a well-fitted mask and physical distancing in public. And just, you guys could read this too, but wearing the mask and maintaining physical distance is still important, especially if you're also meeting with unvaccinated people from multiple households. You want to avoid that. And I think this is also why President Biden said small gatherings by July 4th. We want to avoid the much larger gatherings that we are seeing currently on spring break.
I have to tell you, the best pictures I'm seeing on social media now are grandparents finally getting to hug their grandchildren. And it is awesome. The grandchildren, and we talked about this last week, the young children are so good about wearing masks. It doesn't seem to bother them at all. And now they can finally hug grandma and grandpa. And that's amazing. So again, we are live on Facebook, on YouTube, on Twitter, on Sri Srinivasan's LinkedIn. We are so happy to have people watching from all over. Margaret Ambrosino is watching from Brooklyn. I saw something else, but it flew out of my head. Sorry. So yeah,
I can't even see that.
my eyes are going in different directions. We are so happy to welcome our guests, Marina.
Yeah, so our guests are Vic Pamoukian, vascular surgeon, assistant professor of surgery at the Zucker School of Medicine and Northwell Health, and he practices at Lenox Hill Hospital, and Dr. Nicole Sutton, pediatric interventional cardiologist, who's director of invasive cardiology at the Children's Hospital of Montefiore and associate professor of medicine. Nicole and Vic, welcome. Thank you.
Oh, good morning, everyone.
Morning. Thanks for having us.
Thanks for having us.
We're so happy that you're here. We have so much to talk to you about. But before we get to the medicine part, let's get to the life part. So, Nicole, we had talked a little bit beforehand about the sort of paucity of women in pediatric interventional cardiology. Wondering how you found your passion, how you got there, and what the numbers are for your specialty.
Sure. So I was always interested in pediatrics. I wanted to be a doctor since I was very young. And when I was in medical school, I found interventional cardiology, actually. I really enjoyed adult cardiology and the interventions there. But when I got to pediatrics, it put together the two things I really liked, which was working with children and working with my hands and doing interventions. I briefly toyed with the idea of doing surgery, heart surgery, but it wasn't the right fit for me. In pediatrics in general, pediatrics is an overwhelmingly female field. However, in a lot of the subspecialties of pediatrics, there are more men than women. And pediatric cardiology has a little bit more men than women. There are, within pediatric cardiology, there's many different subspecialties you can choose. And interventional cardiology, being one of them, has slightly more men than women. My program was fairly mixed. We had a good number of female attendings and fellows who went into interventional cardiology, but that was not the case everywhere. And overall, there are definitely more men in interventional pediatrics than in regular, say, pediatric cardiology. But we have recently actually found one of my former mentors just started a group of women in interventions, and it's for women interventional cardiologists. And it's been a nice way to get more junior people involved, get to know people, get to help them form connections to move on in their careers.
So I have to give a shout out to your institution, because Montefiore was woke well before anybody was woke, because otolaryngology at Monty with Dr. Rubin at the chair had at least 50%, if not more, women residents. He never did not believe that women could be surgeons, right? So I think there's something in the air up there in the Bronx that's really good.
Yeah, so we do have actually, even now, our fellowships, our residency is pretty well mixed. And it's a nice thing to be able to show, people that it's doable. So, it's hard sometimes to imagine how your life is going to look like if you've never seen anyone else do that. When I was training, I actually didn't train at Montefiore. I trained in in Boston. There were plenty of female attendings with children working in that program. And so it was easy to see how you could put all of those things together.
It's wonderful to lead by example. At NYU, the surgery department has probably the most female faculty, and actually the residency is also at least 50% most years. One year we were like, all the chiefs were women, except for our there's an integrated residency, right? So the cardiac guy, there was one guy, so it was all of the lady surgeons, and then one. But it was very impressive, and it's always, as I said, wonderful to lead by example. Speaking of which, Vic was my resident, and
I was going to say that.
Yeah,
you stole that from me.
Instead of joining me in minimally invasive surgery, he was like, you know what? I think I really want to do vascular. So Vic, tell us what drew you to doing vascular surgery, which, by the way, I find very intriguing, and I've always loved vascular, except for a lot of the vein work. But you talk
Right.
about you.
Right. So when I was a resident, Marina was my attending, although she looks so much younger than me and still maintains that beautiful look of hers. And she was a good trainer. She was a good mentor for me. Then I had another great mentor who took me under his wings, Dr. Ahmed. And I loved doing the surgery. I loved the intricacy of the major surgery, the aortic aneurysm surgery. I loved doing the microvascular surgery, whether it was bypasses to the leg and the carotid surgeries. And also, vascular surgery is not just a surgical specialty. It's also almost a family medicine kind of specialty. I see patients with diabetes. I see patients with hypertension, carotid disease, cardiac disease. And so the patients stay with me for life. We don't just operate on them and they go away. My patients see me at least once every 6 months to either check on their bypasses, check on their carotids, check on their aneurysms. So the patients maintain their relationship with me. And the great thing about that is that I can see them grow, I can see them get old, and the families are there with them. So I like that part of it. I like sitting and talking to patients. I love being in the office and seeing patients. I know it doesn't correlate well with surgeons that, usually they like to be in the OR a lot. I actually enjoy being in the office and seeing patients and talking to them because that kind of gives the path to maintaining great care to patients.
I love that, actually. It's actually one of the reasons I chose ENT is because we see patients of all ages, but we see them over the course of their lives. So I know people for 20 years, 25 years, I've celebrated their life experiences with them, which is extraordinary. Let's shift gears and talk a bit about how the heart works in a normal condition first, Nicole, and then what are the kind of things that can happen in utero? I know that the heart is fully formed by, I think, 4 weeks in utero and is beating at 8 weeks. And, Marina and I have definitely both had the pleasure of hearing our baby's heartbeats in utero. Can you tell us on the first graphic, how does the blood flow through the heart? And then talk to us about things that can go wrong.
Sure. So as you said, yes, the heart is one of the first organs that works in utero and needs to work in utero. So if it does not work, the fetuses will actually get sick. And that can have some impact on which diseases we see in newborn babies. So when we talk about the normal blood flow through the heart, the first place that I usually start was where the blood comes back. So the blood comes back to the heart through the superior and inferior vena cavas, which are the blue structures coming into the right atrium. That is the blood that's been used in your body. It had all the oxygen taken out of it. And that's why we often draw it as blue in pictures. It goes into the right atrium, and then it goes to the right ventricle. And from the right ventricle gets pumped into the pulmonary arteries where it goes into the lungs. In the lungs, the blood gets oxygen and then returns via the pulmonary veins to the left atrium. From the left atrium, it goes into the left ventricle, and then the left ventricle pumps the blood throughout the body from the aorta. And so the blood will make that circuit around your body every, either 60 times a minute, 80 times a minute, and depending on your size, it's faster when you're smaller and the heart rate gets smaller when you're bigger. And that's why you see that difference in heart rate between, say, a newborn baby and an adult. Now, the common congenital heart defects are dependent on which part of the heart doesn't form well. So you can have holes in your heart. So that would be something like an atrial septal defect, which is a hole in the top part of the heart, or a ventricular septal defect, which is a hole in the bottom part of the heart. You can have a large hole in the whole middle of the heart that involves the atrium and the ventricles and the valves, and that's called an atrioventricular canal, which you see there on your list. You can have the aorta and the pulmonary artery can get switched around with each other, and that would be transposition. That means that the aorta is coming off the right ventricle and the pulmonary artery is coming off the left ventricle. And other things you can have are problems with your aorta. It can be too small. It can be in slightly off position. So all of those things are things that we can see in newborn babies.
So you have a graphic about sort of 6 facts of congenital heart disease, which Marina found. And I thought these were really interesting. You know, the fact that the heart disease is the most common type of birth defect and really affects 1% of children. And a quarter of these kids need surgery or procedure before they're 1 year old. But almost all of them live into adulthood. So I know you mentioned some of these. What are you seeing where you are?
So yeah, we see actually, you know, congenital heart disease, as you're saying, as you see here, is very common. And it can run the spectrum from very mild things like small holes in the heart to very significant congenital heart disease where the babies need surgery within hours or days of being born. And so that's why you see that there's 25% of these babies need a procedure very early in their life. One of the things that has changed recently in some of these outcomes is what's called the CCHD screen, or it's the newborn screen that we now do for congenital heart disease. So after babies are born, most people know about the newborn screen where we take little drops of blood from the baby's heel to look for metabolic disorders. With this added a few years ago was a screen for congenital heart disease and critical congenital heart disease. What that is that we check the baby's saturations in the upper and lower half of the body within 24 to 48 hours after they're born. And that way we pick up some of those very significant heart diseases that will need surgery very early in life, and that if not picked up can lead to very bad outcomes. So that changed a little bit what we're seeing and how babies are surviving. The other thing that's impacted the long-term survival is a lot of the surgery that has come out in the last, say, 20 years has really made it so that people are surviving longer and longer with congenital heart disease. We have patients now in their 40s, 50s, and 60s who are surviving with congenital heart disease. And these adults with congenital heart disease now outnumber the number of children with congenital heart disease.
That's a wonderful statistic, right? Like to be able to say that we've made such an impact. And, you know, we've seen this in a lot of different aspects that we're not going to talk about today, but like cystic fibrosis is a great example of how we've really prolonged quality of life and length of life with our interventions. So that's really wonderful. And we're going to dive into a little bit that later. But first we have to ask Vic a few questions because there's so much about vascular that many, many people around the world experience. But one thing we want to start off with is peripheral artery disease. And you guys now call it PAD. Or do you say PAD or PAD? What do you say? But
PAD, I think we call it PAD.
Okay, but anyway, so those are issues that can affect you when you're walking, can even affect a lot of, sometimes even the arms. Like, you know, I want to throw out Paget Schroeder because, you know, we love that. But Vic, let's talk a little bit about peripheral arterial disease and how are the common symptoms, and people might be like surprised to know, hey, I have an arterial issue.
Right. So we see a lot of patients who are referred to us in the office who come in and say, oh, my circulation is bad, which is the common misnomer we see in the office. And usually these are patients who come in because they have cold feet, they have cold hands, and usually that turns out to be Raynaud's disease. And Raynaud's disease is a condition where the microvascular, the smallest blood vessels, which are micromillimeters that you can't see with your own eyes, spasm at the tip of the fingers or the toes and in the foot and causes you to have a cold feeling. So that does not denote that you have peripheral vascular disease. Peripheral vascular disease is a condition where the blood in the arteries does not reach the muscles in the leg. And usually patients come in who have peripheral vascular disease or peripheral arterial disease, have a blockage in the artery, which is that the red blood vessel that Dr. Sutton was talking about a few minutes ago. And the blood, when it's coming out of the heart, tries to go down inside the body and splits by your belly button to go to either side of the leg. That artery has a blockage in it, whether it's calcium or plaque or cholesterol buildup. And that does not allow the blood to go through the artery and down into the muscles of the leg. And that when that happens, because our muscles need the oxygen to function, the muscle becomes sore. It almost feels like there's like a noose on your calf, or someone punched you in the calf or punched you in your thigh whenever you're walking. So peripheral arterial disease, the way we know it is a patient comes in and says, Dr. Pamoukian, I'm walking down about 1 block or 2 blocks or 20 feet or 30 feet, and suddenly I feel like someone is squeezing my calf and I have to stop. I can't continue. And about a minute or two later, the pain goes away and I start again and it comes again. So that's when we know that the flow of blood that's going from the heart is not reaching the muscles in the leg. And that's where the intervention comes in to see if we can open up that circulation and get the blood down there so that the patient doesn't have discomfort. So again,
you're fine. Before we go to how we intervene, can we talk a little bit about how people get these plaques? What are some of the inciting factors?
Well, we all know that smoking is one of the biggest offenders. Cholesterol, diabetes, high blood pressure are the main actors in the show. And then whenever you have somebody who has all 3 or 4 of them, or you add them together, the diseases, it causes buildup of plaque in the artery. So smoking causes arterial damage. And the arterial damage, which is the inside lining of the blood vessel that brings the blood, smoking causes, let's say, cracks, just to simplify it. And the cracks need to heal. And when the crack heals within the arterial wall, it causes scarring, and the scarring builds up. And as it builds up, it causes narrowing of the tube. Think of a garden hose, let's say. And as the blood is trying to get out of that garden hose, it won't, because there's buildup of stuff in it. And so there's blood doesn't reach until the end. So again, and you can see on the graphic there, on the left side, there's a normal artery where the blood is going down. And the one on the right side, that plaque is built up, the yellow stuff. It doesn't allow for the blood to circulate down into the leg, and causing that discomfort in the calf, or even ulceration, or like a hole in the skin, or infection, and even can lead to worse situations such as gangrene.
You know, there's a term that is used called intermittent claudication.
Right.
Which is, sounds like you get a French guy every so often. But can you explain what that is and what people should look out for? Because my leg hurts sometimes, but I'm pretty sure I don't have peripheral arterial disease.
Right. So again, intermittent claudication is intermittent, meaning it comes once in a while and it goes away. And that once in a while is always with exercise. So whenever somebody comes in and we tell them you have intermittent claudication, means that when they're at rest or sitting and having dinner or watching TV, they don't have that discomfort in the calf or in the thigh. But whenever they start walking, the pain comes, and then you stop, and the pain goes away. So it's intermittent. That's why we call it intermittent claudication. And again, it's a very pathognomonic finding in a patient who comes in and says, I'm walking with my partner, we're in the store, and at every aisle I have to stop for a minute or two, and then catch up because my leg is hurting me and I can't get through the whole day without walking. Well,
that's a great explanation. We have some questions coming in from our viewers. So we have so many questions for Nicole right now. Miriam Berkeley says, how many different tests might reveal congenital heart disease? So what happens in utero that we might be able to predict this? Because you said sometimes babies need surgery within a couple of hours, days of being born. And then Pasani Annapurna says, Asians have more of this in babies. What's your advice to mothers during pregnancy of what to eat or other ways to prevent or somehow intervene to make heart disease less? And then we have another couple of questions, but let's start with those two.
Sure. So, in general, there's congenital heart disease does generally not run in families unless you have a first-degree relative with congenital heart disease. So your mother, your father, your sister, your brother. If you have someone very close to you with congenital heart disease, we screen the baby, especially while you're pregnant. So everyone knows that while you're pregnant, you have ultrasounds to look at the baby and to check the way the baby's developing. On that regular fetal ultrasound, the baby's heart is checked. And the heart is checked to make sure that there's 4 chambers like they're supposed to be, and that things are connected the normal way. Some of those things, those congenital heart diseases, can be seen very early in pregnancy because the heart's already developed. And when the OB ultrasound shows that there might be a problem or that there is a problem, the patient, the mom, then gets referred to cardiology, pediatric cardiology, for something called a fetal echocardiogram. So we can actually do an echocardiogram like we would do on a person that's outside. So an ultrasound of the heart of the baby's heart. So in the current era, most babies are diagnosed prenatally. So if you have your OB ultrasound and there's a question, you will get sent to a pediatric cardiologist and have a fetal echocardiogram, and then have hopefully get diagnosed with congenital heart disease. Some of the most significant congenital heart diseases, such as when you have 1 ventricle, which is called a single ventricle, instead of 2, most of those are actually diagnosed prenatally. And we sit down and we make a plan with the OBs and with the neonatologists on what's going to happen to the baby as soon as they're born. They may need to be put on medication right away. They may need to have special IVs put in, and they may need to be delivered in hospitals that can handle all of those things. Sometimes, though, the babies are not diagnosed prenatally, and those babies can get very sick, which is why the CCHD screen was developed, was to pick up the babies that were not picked up in utero so that we would know, we could diagnose them earlier and they won't get as sick before they have their surgeries.
Thank you, Nicole, for that. We have more questions coming in. We do love that our viewers ask these great questions. And so, Vic, for you, there are a couple of questions. Chris Ramanathan asks, are varicose veins related to PAD or different? And then Sandra Yin, who's watching, says, watching from West Virginia's Eastern Panhandle, I have always thought we lack vascular literacy. Are there any common misconceptions surrounding vascular health? Easy questions.
Easy questions, right? So the first question with varicose veins, as described before, the varicose veins are the venous side of the body. So varicose veins have nothing to do with peripheral vascular disease. So on the venous side, the varicose veins are just unsightly looking. They can be painful. They can burn. They can itch. They can have eczema. They can have ulcerations. Again, the tissue loss, the hole in the skin. So those can happen from the varicose veins. But if somebody has varicose veins, they do not have peripheral vascular disease, and they don't have circulation issues, because if you have varicose veins, you are extremely unlikely for you to have an issue long-term with your lower extremity, meaning unlikely for someone to lose their leg, God forbid, right? With varicose veins, the most that's going to happen is going to get worse. It's going to burn. It's going to itch. It's going to hurt. And then that can be taken care of. With peripheral vascular disease, if you do not take care of the arterial blockage, you can go on to having ulcers or gangrene or even, amputations. So peripheral vascular disease is completely different from varicose veins, 2 different kind of disease processes.
So, those spider veins, do they always go to the worsening pictures that we saw? Do they start as spiders? Some of us have them, and then do they go on to sort of the bulging, painful skin changes, or do they just sometimes just stop there?
Right. Again, so the spider veins are the small capillaries that are within the skin itself. So the spider veins do not progress to become varicose veins. The big varicose veins that we sometimes see in pictures, if you can put the picture up, the slide back up, those are like grape-like veins that are on the back of the calf or on the thigh. So those are varicose veins. Those are not the same thing as spider veins. So if you have spider veins, your spider veins are not going to degenerate to become varicose veins. Again, those are two different processes happening in the body. And spider veins are treated cosmetically with injections. No surgery is needed for that. And for the varicose veins, we can laser them or surgically remove them to make the leg looks normal. So again, two different processes.
Lasers go everywhere. And then the other question was about any common vascular misconceptions.
Vascular disease hits everyone. But as long as you're healthy and your sugars are under control, if you're diabetic, and if you're not smoking, you can ward off the disease. And you're doing your exercise regimen, you're going to ward off the disease. It's not going to come to you. So there's no significant misconceptions. I think everybody's kind of slotted in their box. As long as you're keeping healthy, it's unlikely for you to degenerate to become a vascular patient of ours.
So, we have a question from Posani Annapurna again about sudden death later, which is very frightening. And I'm going to say that this is may be a difficult conversation for people who are listening to us. But there are athletes that we hear about every year, young, healthy men and women who just collapse on the court or on the field. We have a little bit of a graphic about that, but is this undiagnosed, undetected congenital heart disease, or what is the cause of this, Nicole?
Yeah, so there is an incidence of sudden cardiac death in young, healthy people, and it usually catches a lot of headlines because it's usually, of someone who's very healthy. The classic story is it's a teenage basketball player who dies. Usually, so it can be that you have a structurally normal heart and you have a funny rhythm in your heart, such as long QT syndrome, or that you have a different arrhythmia. So a problem with the rhythm of the heart. It can be an abnormal structure of your heart. That's something like, say, hypertrophic cardiomyopathy. The same type of congenital heart disease that we diagnose in babies, say like babies who turn blue, is not what is happening to a teenager who dies suddenly when they were playing basketball at 18. And those are very different. So yes, what is recommended for athletes, especially competitive athletes, is by the AAP, or the American Association of Pediatrics, is a specific type of questionnaire along with a full physical exam by their pediatrician to kind of screen for some of these things. A lot of the rhythm issues like long QT syndrome can run in families. And some of the structural abnormalities like hypertrophic cardiomyopathy or dilated cardiomyopathies can run in families. So yes, there are some issues that can run in families and that can be associated with this sudden death, especially in young athletes.
Nicole, we want to switch gears and talk a little bit about the congenital heart defects. But one thing I want to ask before we do switch and talk about patent ductus arteriosus and all those things that you actually do the interventions for. I want to ask about like those viral illnesses that athletes can get. Like sometimes we attribute sudden death to something, they got a viral illness and then they developed a cardiomyopathy. And I think our viewers and our listeners are aware of cardiomyopathy just because of what COVID-19 has done after the illness, and then seeing the resultant changes in the heart.
So it is actually not uncommon for children and young adults, teenagers, and even adults to develop something called myocarditis. And myocarditis is an inflammation of the muscle of the heart. And that can be due to a virus. And in children, there's a few viruses that are very well known to do that, such as Coxsackie virus and actually rhinovirus, which causes the common cold. What we've discovered in the last year is that the COVID virus actually causes that as well. So there can be, with COVID, acute changes during the acute illness that are consistent with kind of a myocarditis-like picture. And then there are actually patients who are presenting after having a fairly asymptomatic COVID infection with a picture that we call MISC, which is a inflammatory syndrome that occurs after you've already recovered from your COVID. And that usually is a few weeks to a month or two later. And those patients have usually positive COVID antibodies. So we can see that they had a prior infection, but generally they weren't sick enough during their COVID to be admitted to the hospital. And we have been seeing a fair amount of this in New York and around the United States in children who had an asymptomatic COVID infection. Those patients are treated the way we treat most viral myocarditis, with a lot of supportive care. And they may or may not need to be admitted to the hospital. They may or may not need to be in an ICU, and they may need medicines to support their heart function. In general, most patients with viral myocarditis, their function recovers over time. Not 100% of them recover, but most patients with viral myocarditis do recover.
And that's the good news.
It's very good news. It's a little too soon to know what the long-term impact from COVID, but with other viral processes, they do tend to recover.
Vic, just because we always talk about COVID now, do you guys see in vascular some changes after their infections that you've been seeing commonly?
Yes, actually, during the height of the pandemic, around April or May, we started seeing a lot of young people coming in with significant blood clots, thrombosis, or where the clot is in the vein and the clots go up into the lung and give people pulmonary embolisms. So we started seeing a lot of young people coming into the office or to the emergency room with significant clots within their legs, all the way up to the veins in the abdomen, the iliac veins or the vena cava. And we need to do emergency surgery on them to declot the vein, to take the clot out with suction machines that we have. And so we saw a really significant increase in DVT, deep vein thrombosis, and pulmonary embolisms with patients. That was one. And the other thing we started seeing a lot, because, we deal with the legs and feet all the time, was COVID toes. And a COVID toe is when the patients come in and they've had the virus, and whether it's in the acute phase or in the long-term phase, they have discolored toes. They look purple. They kind of look like they're blanching. They have significant discoloration in the feet, and that did not cause any significant long-term sequela. They usually recover from it. But whenever we saw the blue toes, we started calling them COVID toes, and we're seeing a lot of that still in the office. Not as often as we were seeing them in the fall and the winter time, because now the virus is coming down a little bit. But those are the two things that were jumped out at us. But the DVT and the thrombosis and the pulmonary embolism that we saw was significant, and was very, very scary for us.
So, Vic, did you have to operate on them or remove the clot, or is this something that's amenable to balloon venoplasty, something like that? Can you stick a balloon in there and blow it up and make things go away?
No, there's actually a suction thing.
Right. So the way we deal with the blood clots is from behind the knee, the patient's lying on their stomach. We go in with a small needle with an ultrasound, and we go inside the vein, and we're able to put a suction catheter, and we go up with the suction catheter and we suction the blood clot out of the vein to release the clot out and to let blood flow better, and for us to stop the blood clot from going into the lungs. So we don't do open surgery anymore as much for blood clots. But we were in there on these COVID patients who were quite sick, declotting them, taking the clot out.
That's amazing. I want to get to patent ductus arteriosus and these cardiac issues, but there is a question from Margaret Ambersino saying, we're just sitting around a lot, right? We're either on Zoom calls or we're not exercising as much. What are we seeing from a vascular perspective? Because in the past year, we have been moving less. We're not commuting. There's so much normal activity we're not doing.
Well, there's the other parameter of, COVID weight gain. So a lot of people are gaining weight because of COVID. Everybody's sitting.
COVID-19, excuse me.
Yes, the COVID-19. COVID 20 for some people, COVID 25 for some people. So that's when Marina comes in. I think she helps us lose all that weight. But in terms of mobility and getting around and walking around, it's paramount. I think that every 2 hours or an hour, people need to get up and walk around for 5-10 minutes just to get the circulation going. And it's not from the peripheral vascular disease, the blockage of the arteries that we're concerned about. We're concerned more about patients sitting down for too long, and either they're not hydrating very well or they're sitting in very uncomfortable positions on their chairs, and that's causing to have blood clots in their legs. And we've seen several, in the past year, patients coming in and they're healthy, and then they say, oh, I have a blood clot in my leg. And why is that? Because sitting cross-legged in front of a computer for 6-7 hours on Zoom calls. So again, getting up every hour, walking around the apartment for 5-10 minutes or outside, getting some exercise just to get the blood circulation is helping a lot.
We're finally going to come to you, Nicole. We want to talk about this because this is a common finding, something called patent ductus arteriosus. And it's something that I did some pediatric surgical critical care, and something you're listening for when you listen to the heart, and just if you can, we have a graphic up of what a patent ductus does, and if you can explain why it exists, because it's actually a normal thing to have that patent ductus. If you can kind of walk us through the physiology of it.
Sure. So yes, every single baby, every fetus has a patent ductus arteriosus. And as you can see in this first picture, it's a little tube that connects your aorta and your pulmonary arteries. And the reason it exists is because when you're a fetus, the fetus doesn't breathe. And so you actually don't need a lot of blood flow to your lungs because the baby's oxygen is coming from the mom's placenta. So the PDA allows the blood to bypass the lungs and go to the aorta. The best oxygenated blood that babies have comes right out of mom's placenta, goes in the IVC, and then if it makes it to the pulmonary arteries, you don't need it in your lungs, you need it in your aorta to go to your head and your neck and your body. So you skip it by going across that little tube into your aorta. And when you're born, it generally closes on its own within the first few weeks of life. And the way it closes is that it gets a signal from your body when you take a deep breath and you breathe in oxygen and your lungs open. It sends a signal that you don't need that anymore and that it's time to close it. They're very common, most common actually in premature babies who are born early and the PDA does not get the signal to close on time. They can also persist in full-term babies. And when they persist, they cause extra work. What they do is they make extra blood flow now. Instead of going from your pulmonary artery to your aorta, it goes the other way. It goes from the aorta to the pulmonary artery. And that's because after you're born, the aortic pressure goes up because that's the blood pressure in your body, and the pressure in your lungs goes down when you take those first few breaths. That causes more work for your lungs and actually what's called overcirculation. Too much blood is going through those lungs. In the very long term, it can cause problems with something called pulmonary hypertension, which is high blood pressure in your lungs. It can exacerbate problems with breathing and asthma, things like that. And you don't need it. You also, it can get infected. Say you were to have dental work and a little bit of bacteria gets in your bloodstream, it can get stuck in that area and cause an infection. In general, if you have it and it's causing extra work for your heart, we see that on echocardiogram by dilation inside of your heart. And we can hear it when we listen, it makes a heart murmur. And so we would then close it. Sometimes we need to even close it in premature babies when they're first born, because especially in them, it can make a lot of extra work for lungs that are already struggling to do their job. And we have special devices for that. There's a few there's a few different ones on the market that can be used to close PDAs. And there's a new one that came out about a year ago called a piccolo, which means small, right? Everyone knows that word from Italian. And it's for premature ductus babies. And then there's a few other devices by different companies that we can use in different size PDAs and different size patients. And what you see here is a little picture of a catheter going through the heart across the PDA and putting in what looks like a little plug in the PDA. And those devices are putting this in this way is what I do. That's what an interventional cardiologist does. We put in those devices to close holes. And
we also have a picture, a representation of what you had described earlier, an atrial septal defect.
Yes.
A hole between the two upper chambers of the heart. And, in the old days, this was all open heart surgery.
The old days was like 20, 30 years ago. I was a resident when we were operating to close the PDA. And what we used to do was just tie it. Not me, okay, the cardiac surgeon.
Dr. Colvin used to do it at NYU.
Right. And it was when it was first done, it was almost like murder, right? You're going to operate on the baby's heart and do this. And things have gotten so much better that they could do it and do it so safely and effectively. But this is even better. There's no pain for the child of having a sternotomy. There's, you're not going in. These interventions are really fantastic. So we also have that slide on the ASD. So as Suja and I both are like, yeah, we used to cut chests open and do all this. But we want to show you this slide on the ASD because I think this is a cool device. So if you could just go through this as well.
Sure. So as you can see in the first in the picture, that there's a hole on the top part of the heart between the right and left atria, and that's called an atrial septal defect. And we have actually with this as well a few different devices that you can choose from to close this hole. And we do the same thing. We use a catheter and we can close it with a device. Now, both for PDAs and ASDs, we can't do 100% of these holes in the cath lab, but we can do a lot of them in the cath lab. And the recovery time for the children, and actually we can do this in adults as well, is much faster. So, when you have open heart surgery, you're looking at probably 5 days in the hospital and about 6 weeks of pain from the actual sternotomy. When we do this, you go home the next day and you go back to school. Say we do it on Tuesday, you'll go back to school on the next Monday.
That's really amazing. Yeah, that's really amazing. I think we wanted to talk to Vic a bit about these peripheral vascular stents, right? You talked about how if you're a smoker, if you're diabetic, if you're genetically predisposed, if your diet is poor, you put all this plaque in your blood vessels. So can you talk to us about how you put in a stent and when you put in a stent and when you have to open and remove the plaque?
Sure. So we work, Dr. Sutton and I work with catheters all the time. There's this, thin plastic tube, and we actually puncture the artery in the groin and go through that and go wherever we need to go, whether it's in the carotid artery or in the arm, or whether it's an aneurysm in the abdomen or the lower extremities. We're able to get down and take pictures. And what we do is we inject dye, which is a colored liquid, let's say, and under X-ray imaging, we can see, the garden hose, as I explained before, which is a wide garden hose, and inside of it, you can see the plaque buildup, which is makes the blood does not go through very well. So what we could do with that is, then we can go through that little blockage, and then once we go across it, we're able to put a stent, and a stent is a chicken wire, let's say, and it just plops open and has a radial force, so it opens up wide, as you can see on the graphic on the right side. The mesh wire opens up, and then opens up with a balloon and squeezes that plaque out to the outside wall, allowing for more blood flow to go across the artery. Now, these are just temporizing things. Usually these stay open for several years. A lot of times we need to go back in and see them again and re-balloon it, reopen it up more. So that's why the patients see us every 6 months. We check on the stent with ultrasound and make sure that the flow is maintaining. That's number one. Second of all, if the stent becomes clogged up again, because a lot of these patients, unfortunately, they're diabetic and they're not controlling their sugar, or they can't quit smoking, or they're morbidly obese, the stent can get clogged up itself again. And so we go back in and try to reopen it up. And at times when we are doing this over and over again and the stent is just tired and will not reopen up, then at that point we have to replace the artery with a plastic artery off the shelf, or using a vein from the patient. So those are the things that those are in our armamentarium to get circulation down the lower extremity so the patient can walk and not have ulcers or worse, gangrene.
So unfortunately, we only have 5 minutes left, and we have so much we want to talk about. So I want, Sudha Parekh had written in that she knew somebody who had to be flown somewhere 35 years ago and have a procedure. And I bet you that was for tetralogy of Fallot, and I bet you that was Blalock-Taussig shunt, right? I think. So what I found amazing was that in my inherent chauvinism, I actually thought Blalock and Taussig were both just men who invented something. But in fact, Taussig is the mother, father, grandmother, grandfather, grandsire of pediatric cardiology, and she was amazing. Blalock was a cardiac surgeon. And then there was a third person, and we have a really nice picture of all three people who invented this BTT shunt. The third person was a technologist named Vivian Thomas, and he was an African-American man who actually stood behind Dr. Blalock to tell him where to cut and where to sew to do the first shunt. And this was remarkable. And this started in 1944. And maybe you can talk to us about what happens with this, Nicole.
Sure. So the Blalock-Taussig Thomas shunt, now BTT, is one of the first things that was done in pediatric cardiac surgery that really changed the way that we could manage people. What had been noticed was that in some patients, when their PDA, the patent ductus arteriosus, stayed open, they were able to live longer. And so the idea that Dr. Taussig had was to actually make one. And so they worked with animal models until they figured out how to do that. And it became really one of the most common surgeries that was done, and has been used for many different types of congenital heart disease, such as tetralogy of Fallot and single ventricles, to ameliorate the situation until the babies are older and can maybe have other surgeries.
Our last show, we actually had Dr. Julie Freischlag on, and we made brief mention of the carotid endarterectomy. I think we have just enough time. We have a slide, Vic. My dogs are excited about it too. We have a slide on carotid endarterectomy. If you can just quickly run through and tell us, like, why do you do this? And I actually put that plaque picture up because it's so disgusting that I thought our viewers would appreciate it.
Right. So very quickly, again, the disease process of atherosclerotic plaque buildup, which happens in the legs, can also happen anywhere in the body. It can happen in the kidneys. It can happen in the arteries of the liver. And it can happen mainly in the carotid arteries, which are the two arteries on either side, the right carotid and the left carotid, causing blockage in the blood flow to the brain. And whenever that happens, that plaque that's sitting there on the left side of your screen can form, and it can become almost like an ulcer. It can be almost like cottage cheese, as you can see on the plaque on the right side, the anatomy picture. And that little plaque that can break up and go into the brain can give you a stroke. So that's when we see patients who are smokers, diabetics, hypertensives, who are over the age of 55. We do a carotid ultrasound in the office. If we do find that blockage in the artery, then we go in and make a little cut in the neck, go down, clean up that junk or the plaque or the calcium and whatever it is, and then reclose the artery nicely so that it doesn't embolize, doesn't go up into the brain so we could prevent strokes in patients.
That's fantastic. You know, we started by saying 90% of kids with congenital heart disease survive, but some kids thrive. So on Twitter, I asked if anybody knew a 3-time Olympic gold medalist who had had 2 cardiac surgeries before he was 1 year old, and it was Shaun White,
Yep.
the snowboarder. Can you believe this? He had tetralogy fellow, and he had 2 operations before the age of 1. I have not had any cardiac operations, and I'm not even making the Olympic team. We want to thank both of our guests so much. We were live on Facebook, YouTube, and Twitter. We're carried on WBAI.org and WBAI 99.5 FM, Mondays from 2 to 3 p.m. You can always catch our show again on YouTube, and we're so excited to have spent this hour with Dr. Vic Pamoukian and Dr. Nicole Sutton. Thank you so much for joining us today.
Thank you for having us.
Thank you.
Have a good rest of the day.
As you all know, this show could not happen without credits to our producers who keep this running so smoothly. And stay tuned for next week's show. It's going to be the Hearing Health Show, and we'll have Dr. Shelley Chadha, who's the director of the WHO program for the prevention of deafness and hearing loss, and Dr. Charles Lim, a premier researcher in cochlear implants and music at UCSF, and he's president-elect of the American Auditory Society. So stay tuned for that.
Bye.